from Legnano, The Dark Side of Chiari, the first book written by patients, for patients and doctors. We have Dr. Colla, right?
Sì, buon pomeriggio a tutti.
Good afternoon. My name is Samuele Collo, and I'm an anthropologist, so I'm not an expert at Chiari. It is very rare for an anthropologist to speak at a medical conference, and I'd like to thank you very much, therefore, for your kind invitation. I'll try to be very concise so that you will invite me again next time. I'm here to illustrate the project of the IMA Child project, consisting of a booklet with many different descriptions of the experience of our patients. This book mirrors very much the anthropological approach, because the biological event is very closely connected to the psychocultural experience of patients. To anthropologists, the biological event per se is not particularly relevant compared to the experience of the patient, because it is about interaction between the biological event and the experience of the subject. This book, entitled Dark Side of Chiari, starts from these assumptions, this interaction between suffering and pain. Pain oftentimes is latent, but suffering is something else. And so patients end up in this sort of paradox, because there is a different approach to the problem depending on what side you are, and therefore there might be also a misunderstanding between the two parties. Often pain is dormant and silent. That's why we entitled the book The Dark Side of Chiari, just to refer to this silence, which is typical of the Chiari patient. But often the patients can tell, however, can speak, and therefore tell us their story. In these 2 days, we relied on some maps which reflect our territory, but that are not this territory. And so these stories, this book is meant to have patients vent their concern and vent their pain, and so that they can express their feelings about their body and about their experience with themselves, with the others, and with doctors. So this is only what I meant to say. This book is definitely very interesting, to be able to better understand patients and don't just look at them as simple maps. Dr. Francaviglia?
Che ha due comunicazioni. Una...
Mr. Francaviglia will hold two presentations, a 5-minute presentation and a 10-minute presentation. He can hold both in a row. This is just a slide to show you that Caltanissetta, where I come from, is a sea town. I will talk about a case series including adult patients alone. If Chiari malformation is congenital, as it were, and determines an alteration between container and content, what are our indications for surgery? Only if there are neurological signs or hydrocephalus or syringomyelia do we intervene, and very rare, we think it's very doubtful to surgically treat Chiari 1 if there's just a headache or a tonsillar descent. The objectives are restoring the correct CSF flow, and the others listed on the slide. Posterior decompression is the treatment of choice, especially if there's a syrinx. It's preferable in the management of syringomyelic syrinxes, and in our view, there are fewer complications. It consists of suboccipital craniectomy, opening of the dural plane and shrinkage, opening lacuna and lacunae, and this is our preferred technique, followed by duroplasty. These are our case studies. There were 30, 18 were associated with syringomyelia, 16 cases of Chiari 2 were associated to syringomyelia, and 22 patients were plain syringomyelia. Since I come from Caltanissetta and the previous colleague comes from Genoa, which is far away, I've had to, as it were, make an effort to become aware of Chiari syndrome, because I think that Chiari syndrome is much more present in the south of Europe than in the north of Europe. The first case report is a Chiari 2 female patient with medullary compression and a cerebellar syndrome. This is her neuroimaging study. You can see how distorted her brain stem is. This is the second patient with syringomyelia and Chiari 1, a female 41-year-old patient. Symptoms were determined by syringomyelia and cord compression. Neuroimaging showed the presence of a syringe. We prefer this prone position because it helps tonsil descent. Suboccipital craniectomy was limited. Most of the times the arachnoid is thickened. Nobody pointed it out today, but often descended tonsils are asymmetrical. I couldn't provide any logical explanation to this. We prefer opening the dura, decompressing and removing lacunae. I always like exploring the side recesses, especially if there are cranial nerve deficits, in order to release those as well. Now I'm going to show you a short video. No, I'm not, because the video is not working. Can maybe someone help me with the video? We prefer performing a Y-shaped opening of the dura. We carry out this clover-shaped opening because we, as I said, prefer opening laterally up to the condyles. I always open the dura, which most of the time looks thick. So we open the arachnoid. I pull the tonsils down as much as possible, and then I perform shrinkage of migrated or displaced tonsils. We are not aggressive because I believe that when decompression is required, true decompression should be performed, and one shouldn't just limit oneself to enlarging the foramen. I open the fourth ventricle and remove all lacunae until I see the CSF fluid flow out of the fourth ventricle again. I pay a lot of attention to lateral decompression until I release the nerves. Here's the plexus that's been coagulated. So as you see, we try to open the fourth ventricle as far up as possible until CSF starts flowing out again. As a result, we obtain a well-decompressed cavity. The most fearful complication here is the CSF fistulae. Here are our results. Clinical improvements have been obtained in 80%. 15% of cases, and this hasn't been mentioned today, are stable. These are people who have severe damage, and most of the time their picture remains stable. More specifically, I'd like to note a worsening in this deaf and dumb girl who had a deficit at the 9th, 10th, and 11th cranial nerve. Perhaps we exaggerated when coagulating the tonsils, and therefore the patient had a worsening, albeit temporary, at 6 months. Our conclusions are as follows. Our treatment of choice is decompression, which is the most effective and less complications burden technique, which we prefer performing. So this is the end of my first presentation. And now I'm going to hold a second presentation. But I'd like to note that when stabilization is necessary, which we never do in Chiari patients, that is in junction malformations. By the way, we have stabilized the junction of 45 patients using this vertex system that's based on screws and hooks. This is a Down syndrome female patient with a C1 dislocation and medullary suffering. This is the old system. But this is another case report. It's a 68-year-old woman who came to our observation due to an invagination of the dent, of the odontoid, and we proposed transoral decompression, but she resorted to other surgeons who carried out a C2, C3 decompression with stabilization with an old R-shield method. After a year, this lady came to our observation because of an ulcer of the ascit and several symptoms such as dysphagia. So at this point, we placed the vertex in the appropriate position. We decompressed the posterior cranial fossa, which hadn't been previously decompressed. The advantage of this system is that since it is quite versatile, it makes it possible to decompress the posterior cranial fossa quite easily. These are the results. And at the same time, to traction the cervical spine as far as it's useful, considering the latest report that reports the usefulness of traction to solve muscular spasm problems. Thank you. There's time for one question. You may go. Okay. Let us leave the floor to Dr. Ria, who will talk to us about the analysis of both surgical complications in the treatment of Chiari malformations according to the experience of the neurosurgery department of the Hospital of Verona.
Hai 10 minuti,
Sì, con un minuto in più. Grazie. Pagando.
Buonasera a tutti.
Good evening to all of you. I'd like to thank the chairman and the colleagues in the audience. My name is Dr. Ria. I come from the neurosurgery department of the hospital of Verona. And I would like to illustrate and raise an issue which is still open about the case of a young man that was referred to us. Our retrospective study is intended to examine the postoperative complications in patients treated surgically with Chiari malformation. All this in the light of our experience at the neurosurgical department of Verona. The goal of our study is to assess the possibility of decreasing the incidence of post-op complications in patients that undergo surgery with Chiari. Our retrospective analysis referred to the last 11 years, January to 1998 and April 2009. We operated on 132 patients above 80 years of age, prevalently females. In particular, we operated on 118 patients with Chiari type 1 and on 14 with Chiari type 2. 62 patients as total had an associated syringomyelia in the cervical or cervical portion, dorsal portions. As to our experience in surgery in terms of in Verona, we have a standardized protocol that involves the osteodural decompression. We prefer the semi-sitting position, and in all patients we performed atlanto-suboccipital median craniectomy. In 20 out of 132, we had to remove the posterior arch of C2. And the duroplasty is our current open issue. So this happens in the semi-sitting position. This is the arachnoidal lining, and here we see the cerebellar tonsils. We try to detach, to free up the tonsils, and then we coagulate this area. Our current problem that still poses a lot of doubts is to understand how we have to go about performing duroplasty. Until January 2008, we with no major problems, we have used treated bovine pericardium, but then since later it was no longer possible to use bovine materials, from February 01 to November 07, we used treated horse pericardium, and we saw that in these 6 years we had many complications that, on our opinion, could have been avoided, and therefore we decided, since December 2008, to use for duroplasty a graft, an autologous graft, harvesting fascia lata. Of course, the dissection is lateral, a 7 centimeter dissection to expose a dural patch that, of course, then we suture. The post-op complications were came about in 10 patients. We believe that we can decrease most of all the complications that were the most severe, aseptic meningitis or pseudo-meningocele or hydrocephalus, secondary hydrocephalus, and then other complications had an incidence below 1%. The retrospective analysis shows that standardized surgical technique can be very helpful, and the surgeons themselves in the last decades have operated this chiari malformation based on this technique. What has changed is the material that we have used. In 2001, 2007, we see we have the highest number of complications, the period in which we have used horse periosteum, and the meningocele and hydrocephalus could have been avoided. And then with fascia lata in the last decade, we haven't reported, so far at least, any complication. These are some very important cases. A 47-year-old woman, chiari type 1, syringomyelia, was referred to us and was operated in November 2005. The patient immediately said that she was fine and had no problem, and so she waited a lot, and she underwent the first follow-up visit after 14 months. Actually, she was symptom-free, and the magnetic resonance 14 months after showed a remarkable shrinkage of syringe, ascent of the tonsils, restoration of the cisterna magna, and the pseudomeningocele. She has been monitored until the last MRI in January 2009, and since she did not develop any problem, we haven't operated on her. This is a completely different case, a 51-year-old woman with chiari 1 with major syringomyelia, operated in May 2007. 2 months after surgery, we had a new hospitalization because many symptoms developed, and actually the CTs showed this pseudo-meningocele that you can easily see. This is CT, and MRI shows a good outcome of the chiari malformation surgery, but we see this large pseudo-meningocele, and therefore on 31st of July 2006 we decided to redo the operation, and in the operating field we saw the fistula. So the fistula through the horse pericardium patch that we closed with the muscle, and we used once again horse pericardium. And then in September of 2006, we had again a worsening of symptoms, a new relapse of pseudomeningocele, and also we had hydrocephalus. This is the MRI that shows the larger pseudomeningocele, and therefore we had the third surgery. And on this occasion, we decided to close the fistula and to harvest the patch from the rectus of the abdomen. Of course, here there is no more meningocele or relapsing pseudomeningocele, but in the meantime, hydrocephalus developed, and so we shunted the patient with an adjustable valve. This is the final CT that shows a clean surgical focus. And, our discussion is very short because we actually have presented our experience, and we have seen that the major complications, the highest number of complications were associated with the use of horse pericardium. A decrease was experienced with fascia lata graft, and probably we will be using this system until we do not have a more reliable synthetic dural patch. This is a young 20-year-old patient that was brought to our attention with a clinical picture with occipital nucho headache and dizziness. Magnetic resonance follow-up was magnetic resonance was done on 21st of September last year, and we see the descent of the tonsils below the foramen. But what made us very dubious was this posterior fossa kyst with a septum, and therefore we discussed the case, and also this magnetic resonance imaging, and also talking with the neuroradiologists, we have realized that there is a compression on the cerebellar convexity, and in the axial slices we see that there is still space between these leaflets. We carried out a cine MRI very recently, 3 days ago, and we actually see no CSF movement in this area, and so we would like to know whether you see an indication for surgery. What kind of surgery would you perform? Would you explore the cyst, or would because we are afraid that this tensed cyst could be a Chiari too, or would you just wait and see? What about symptoms? It's in there is major headache, a severe headache, and dizziness. And so he cannot lie supine to sleep. As to the rest, there are no other major symptoms. This is the MRI image. The septum, perhaps you can see. Yes, we can see the septum.
Sì, però forse si può fare un intervento andando a esplorare anche la cisti, allargando.
Perhaps we can perform a surgery and explore, investigate the cyst. Well, the posterior fossa seems large and not small. Perhaps we should also explore the rest of the cord, of the marrow. So you would suggest a complete magnetic resonance imaging of the entire spine? Yes, I would also test whether the headache is associated with an increase of intracranial pressure. Would you have any other suggestion? Dr. Cabucci, what would you do?
C'ha la cefalea quando è sdraiato, capito?
No, he has headache in a supine position, I mean, when lying down, and dizziness.
Novembre 2008.
November 2008. Would you section the phylum? No, I would do a craniectomy, and I would go above the cyst. And in the other cases, in your cases and the cases of Francaviglia, perhaps craniectomy in standard Chiari is perhaps even too large. We believe it's not so important to go very high on the cerebellum. You should stay more at the level of the foramen. Dr. Talamonti, from the team of Milan, Niguarda, Chiari 2 malformation treatment and syringomyelia, series of 231 patients operated on with
You have 10 minutes. This is our case series. These are 231 patients with a median follow-up of 11.3 years. Let's focus on Chiari-2 malformation. All of these are myelomeningocele patients, so they have CM2 malformation. In 98.8% it was present. It was symptomatic in 74 patients, and serious symptoms were in 26 patients. Mainly mild symptoms were swallowing disorders that resolved as children grew. The distribution showed two peaks in different ages, at different ages, below 3 years and above 11 years. Below 3 years of age, there was brainstem compression with apnea and cranial nerve disorders, and above 11 years of age, there was mainly a symptomatology that was related to spastic tetraparesis, that is cervical cord compression. Treatment in all these patients who also had hydrocephalus, which is no news since they had myelomeningocele. We tried to review the shunt, at least as a first treatment, and this reduced the symptoms in about half of these patients, whereas in half of them the shunt didn't work, so we had to perform a craniospinal decompression. This slide talks about foramen magnum decompression, but in fact all these patients had a rather large foramen magnum, so decompression was mostly cervical. This significant patient, had a shunt and was operated on at birth. He came to our observation with vomiting and headache. RM showed enlarged ventricles. We suspected that the shunt was malfunctioning. The shunt was reviewed. The ventricles went smaller, but the girl was still sick, and soon new symptoms appeared, which made the diagnosis clearer and moved our attention to the posterior fossa, which we hadn't considered thus far. So then we performed surgery on her. She is the only one that on whom we only performed bony decompression without tumorin nodura, and we will see what the problems were, and the outcome was positive. This is a similar but opposed case. This was a girl who was operated on at a neonatal age of craniospinal decompression, and she came back with symptoms that pointed at a Chiari relapse. Before we touched the posterior fossa again, we looked at previous tests again, and on comparison we saw that there was some CSF fluid around the brain stem, and the ventricles that looked normal were not normal, so we reviewed the shunt. Genetic mechanisms of Chiari are as follows. Immature brain stem. This has been reported in 20% of cases, and it's probably responsible of the unsuccessful outcomes. This was an unsuccessful outcome. This little girl had no breathing activity at birth. On day 3, she underwent RM with a very low torcular and a very small posterior fossa. On the same day, a shunt was performed, which didn't work. We then decompressed her at the craniocervical site. This decompression was mainly cervical, as you see. Unfortunately, the outcome was not successful, and on day 38, the girl died. On autopsy, no bulbar nuclei were visible, but fortunately, it's not always so. With overcrowding, the decompression mechanism is much more easily seen. There's always this band at the atlanto-occipital ligament, which makes an impression on the cord, and probably this is why with Chiari-2 it's always better to also open the dura. In spite of a post-op course which involved tracheostomy and PEG, which is quite normal in these children, long-term results have been quite good as for Chiari malformation. This is another patient who was completely asymptomatic in terms of Chiari, in spite of the severity of the clinical picture. Symptoms appeared at 6 months of age. We performed a a shunt, and then we decompressed because there was no improvement. Often, unlike in Chiari 1, in Chiari 2 it's necessary to decompress 2 or more lamellae, going down to C2 and often to C3, sometimes even C4. We always prefer performing a laminoplasty with a bone graft to try and prevent as much as possible post-op laminectomy complications. And we haven't had huge problems after all. This is the same patient. This is a post-op picture showing opening of the canal and improvement of symptoms. What should compression be like? Just bony decompression? Not always in Chiari 2 patients, because often the occipital ligament is ossified, and therefore it's difficult to detach, unless in Chiari 1 patients where dural delamination is easier. Looking at, based on the indications by the Chiari Institute on minimally invasive surgery, I would say that this is not indicated in Chiari 2 patients, even though in the only case in which we performed it, it went well. As for ventricles, we always try to preserve the arachnoid, and we try to restore it only when there is a severe arachnoiditis, such as in this case. But apart from that, we perform an extra-arachnoid intradural decompression, thus trying to preserve and spare the arachnoid. Results were good apart from the girl who died, especially in patients with a shunt that solves all symptomatologic problems in half of the patients. The other half of patients was solved by means of the craniospinal decompression. As for syringomyelia is due to an altered CSF dynamics at the foramen magnum, but with hydrosyringomyelia it's not always so. 63.7% of patients with syringomyelia which didn't pose any problems during follow-up progressed and required surgery. These were fully asymptomatic and non-progressive patients throughout follow-up. So, as you see, they are much larger than 5 centimeters diameters, and they exceed all the parameters that were indicated, but none of these patients evolved and required surgery. This is perhaps to show that these syringes are different to syringes without myelomeningocele. Another alterations that we've seen quite often are intradural extramedullary cysts that also tend to remain stable and not to evolve and to stay asymptomatic during all of the follow-up. What's our workup? If these syringomyelia patients are followed up, if they're symptomatic, we try to figure out whether we're confronted with syringomyelia, with foraminal syringomyelia that is altered CSF dynamics or something else. And of course, this leads to a different treatment, whether it's foramen magnum decompression or something else. This is a typical case. There seems to be a development of the syrinx that was back in 2003, but as you can see, the foramen magnum is free. There's CSF flow, no alteration. This child was completely asymptomatic. He was conservatively treated, and after 4 years, the cyst volume was spontaneously reduced. Here, the opposite happened. This was a symptomatic patient with altered CSF flow. Foramen magnum decompression was performed, and the cyst was reduced, and clinical progression stopped, and there was a recovery. The follow-up was the same as with all other patients. This is ventricle. We usually try to spare the arachnoid. We couldn't in this case. This patient relapsed and then required multiple laminectomies and cyst shunting, detethering, retroperitoneal shunt, and after 10 years she is quadriplegic, and I don't think there's nothing we can do for her anymore. This is the only terminal ventriculostomy case. Here it's difficult to tell to what extent syringomyelia plays a role and to what extent it's secondary to myelomeningocele. So we detethered and resected the filum terminale by means of terminal ventriculostomy. The outcome was successful, and I'd like to remind you that our group performed detethering as early as back as 15 years ago. In 6 patients, surgery was required, and that's the breakdown of results. Talking about Chiari 1 and Chiari 2 together is incorrect. These are 2 completely different disorders. Chiari classification is not a grading system, so Chiari 2 is not a more severe form of Chiari 1 malformation. They're completely different, and perhaps it's not correct to talk about them together and to report them together. Here we have talked about our 10-year case series of Chiari 1, and as you see, the differences are remarkable. The differences become apparent when we compare the syrinx in both adult and pediatric patients with myelomeningocele in our case series of the last 10 years with syringomyelia without myelomeningocele. With the exception of some cases of foraminal syringomyelia, which are also found in myelomeningocele, in other cases this was a malformation-related syringomyelia, which probably didn't have anything to do with an altered CSF flow at the foramen magnum. Thank you for your attention. The speaker was extremely fast. We apologize for the scanty translation, but he was too fast to translate properly.
Chiamo Iannelli di Pisa, malformazione di Chiari tipo 1 associata a craniostenosi.
Professor Iannelli from Pisa, Chiari 1 malformation type 1 associated to secondary craniostenosis.
Buonasera, io spero di essere anche più breve del tempo previsto, anche perché il caso che volevo sottoporre alla vostra attenzione è già...
The case I would like to discuss has already been partially discussed after the presentation by Professor Solero. In any case, I myself believe that the ideal treatment of Chiari 1 is duroplasty, and therefore of the treating the intradural portion. The dural opening makes it possible to eliminate the adhesions that are present in Chiari 1, and with bipolar coagulation, as we can see in the on the right-hand side, we can expose the obex that, as Dr. Lena said, is larger and open. However, this is a 12-year-old boy that was referred to his patient for a worsening symptoms that are the typical symptoms of Chiari 1 suboccipital headache, and then pain radiating down to the shoulders, and then swallowing disturbances, especially with fluids, and later on lower limb asthenia, particularly severe. He was a soccer player, and he couldn't play soccer for more than 10 minutes. CT was carried out, ventricular dilation was identified, and he was referred to the neurosurgeon. And this boy, of course, shows untreated craniostenosis, and there is a very clear element, because in the first year of life he was treated for a severe arteriotoxicosis that probably caused this craniostenosis. Clinically speaking, there was no papillary edema. There were good excessive reflexes in the lower limbs and the nystagmus. Besides the dilatation of the lateral ventricles, we see a remarkable craniostenosis. Given to these symptoms, we defined this patient as a Chiari 1 patient based on the CT findings showing also a syringomyelia in the cervical dorsal portion. However, on my opinion, this posed problems in terms of treatment, because in the end, this patient could undergo 3 different surgical treatments. The standard suboccipital decompression, cranioplasty, and I myself decided also to record intracranial pressure, and we discovered that despite no papillary edema, this patient had high peaks of endocranial pressure and baseline values that were borderline. So they were within the norm, but high. I developed a plan with the family, including initially a shunt, because hydrocephalus was regarded as a consequence of the craniostenosis, and therefore I decided not to opt for a third ventriculostomy. And then I said, later on we will understand whether to perform suboccipital decompression. And after shunting, symptoms improved, and this is the neuroradiological picture. After shunting, the syringe disappeared, but Chiari 1 persisted, not only because of the tonsils in the foramen magnum, but also because of the absence of cisterna magna. That is a very clear sign of Chiari 1. 2 years went by, and the clinical picture is unchanged. Somehow I think that we can consider this patient as a symptom-free Chiari 1 patient, but actually it is not such a patient, because he had symptoms in the past, so he can be a patient at risk. And therefore my question is, do you want to be happy with these results, or do you want to do something else? Is this patient at risk or not? This morning we said that children can do sports, and he has resumed soccer playing, and after he's being monitored for 2 years now, but perhaps this might not be the best strategy. Anyone wants to answer? Personally speaking, I would monitor him and see how the situation unfolds. You solved syringomyelia, you solved the clinical symptoms, and so he can do his sports activity with no problem. Dr. Ver